Thank you for joining us today. I think we still have some folks coming in from the waiting room. Welcome to our Rural Oral Health Seminar Series. Today we're talking about community engaged data collection for oral health justice. I'm thrilled that you're all here today, and I'm thrilled to jump into our presentation. So we can head to the next slide. My name is Liz Flannery. I'm the Director of Education and Leadership here at AIDPH. I use she, her pronouns. I'm going to give us some quick housekeeping and overview before I hand it over to our didactic presenter, Dr. Gina Thornton Evans. After the presentation, we'll have time for Q&A as well as a community discussion. We always strive to have our sessions as engaging and interactive as possible. So please think through your questions and get ready to discuss. You're welcome to post them in the chat as we go through the presentation, and we can pull them out to that Q&A session as well. And if you have any issues with Zoom or anything else as we go along, please put that in the chat as well. You can head to the next slide. We want to say thank you to our partners. You can head to the next slide. Again, just some housekeeping. We are recording this session. The recording will be available on our Academy and our website afterwards, as well as the session slides. Please avoid sharing patient health information. We invite you to share your email and organization in the chat. And again, if you have any questions about Zoom or the presentation as we go along, please post those in the chat as well. Go on to the next slide. Sharing a little bit about AIDPH. We are a 501c3 nonprofit. Our mission is to empower our community to advance oral health through science, education, and advocacy. It's a culmination of those things. We're bringing in science and research into an educational community programming here today. We do this work because we have a vision of a justice-oriented oral health system. Can head to the next slide. We have 4 communities of focus here at AIDPH. That includes LGBTQIA+ people, veterans, people with disabilities, and people living in rural communities, which of course is the focus of this seminar series that we're doing today. Can head to the next slide. Again, I referenced our Academy. We have a digital learning space where our AIDPH Academy lives, which is the umbrella for all of our education and leadership programming. We strive to offer a variety of diverse programming, so there's something that fits everyone's schedule and needs, from a one-time series webinar to a series like this, learning collaboratives. We have certificates attached to a lot of our programming, including the seminar series here today. Also CEUs. We go up to fellowships, which are a bit more intensive, and we culminate in our colloquium, which is our annual in-person conference. And we'll share some information about registration for our 2025 conference at the end of this seminar. Head to the next slide. So just touching quickly on our session norms. This is a series where each person learns and each person teaches. We're respecting everyone's point of view and their lived experience. We use first names to facilitate equity in the discussion. We invite you to add your pronouns to your Zoom name and to introduce yourself with your name, your organization, and location when you're speaking. Again, we strive for this to be interactive, and we have time for community discussion at the end. Please turn on your video, but keep yourself on mute until you're ready to talk, and limit environmental distractions so we can be respectful of our time and space here together. And again, just remembering to respect that patient health information in our discussion portion. Can I head to the next slide? So this is an overview of our series that we're doing this year. I know I've seen several familiar faces and names. We have folks who have been on our entire session series, We're focusing on navigating rural and tribal oral health solutions using a community compass. We have CEUs attached to each session and a certificate that you're able to do when you complete each session, as well as an evaluation after that. We'll talk a little bit more about that at the end of this session in our next steps. Can head to the next slide. This is just an overview. If we go back to this slide, we have an overview of the sessions we've done, what we're doing here today, and what we have upcoming in December. Again, we're talking about community engaged data collection for oral health justice. We can go to our learning objectives, which Dr. Thornton Evans is going to talk a little bit more about in her presentation and what we're learning here today. Can head to the next slide. And so without further ado, I'm thrilled to pass the mic off to Dr. Gina Thornton Evans, who received her doctoral of dental surgery degree from the University of Michigan School of Dentistry and a Master of Public Health from the University of Michigan School of Public Health. She joined the CDC as a dental officer on the Surveillance Investigations and Research Team. She's a diplomat of the American Board of Dental Public Health, and she has represented the Division of Oral Health on various committees and work groups related to health disparities, periodontitis, diabetes, and maternal and child health. She oversees the management of the National Health and Nutrition Examination Survey, or NHANES, which we're going to talk in detail about today, the oral health component, and focuses on the strategies to improve and enhance surveillance measures for oral health. Currently, she serves as the Division Director for the Division of Oral Health and as the Director of CDC's Dental Public Health Residency Program. So, Dr. Thornton Evans, please take it away. Thank you so much for being with us today.
Yes, thank you so much for the invitation. I'm really happy to be able to be here today and talk a little bit about surveillance efforts at the national level. Just wanted to share with people, I know that they saw the learning objectives. And what I'm going to try to really focus on is just some of the challenges with respect to collecting data, whether you're trying to look at it by race, ethnicity, education, income status, et cetera, but then how that plays into getting representation from persons that have disabilities, individuals that rural versus urban. Like I know this is a heavy focus on this series, but then also some of the other challenges with respect to the recruitment of individuals to participate in these surveys. And then I'll kind of focus too on some of the legislative language that allows us to collect that information. So can you go to the next slide, please? So as a federal employee, I have to just let everyone know that anything that I present in this presentation is not necessarily an official opinion of the Centers for Disease Control, and I don't have any conflicts of interest to share. So I kind of told you about the context of those learning objectives and what, I hope to accomplish during our time together. But just to kind of give you an overview of the outline of the presentation, I'm going to talk a lot about, in some respect, a high level overview of what CDC is, what is Healthy People and why it is done. I'll focus a little bit on some select Healthy People 2030 objectives with their estimates. I'll mention the leading health indicator and why it's included in the oral health lane. And then what is the National Health and Nutrition Examination Survey? Why do we use this data? And just some key takeaways that will help us get into the discussion part. So this is a photograph of the Roybal campus, which is considered the headquarters for CDC in Atlanta, Georgia. This is the Clifton Road. So this would be where Dr. Mandy Cohen, who is our current agency director, would be. There's other offices there, like the Office of Readiness and such. But there are many other campuses in the Atlanta, Georgia metropolitan area. Next slide. This is a snapshot of the Division of Oral Health. We're a relatively small division in comparison to the 8 other divisions within the National Center for Chronic Disease Prevention and Health Promotion. And right now we have 4 operational teams, which includes comms and policy, evaluation. We also have the surveillance and investigations and research team, and then the program services team. And then a newer one we just added is the informatics team. Next slide. So before I really get into the portion about NHANES, I kind of wanted to set the stage in terms of the Healthy People history. In 1979, the Surgeon General's report for Healthy People This was led out by Dr. Julius Richmond, who was Assistant Secretary for Health at that time and Surgeon General. This first report was to establish national objectives to be achieved by 1990, and this included a chapter on fluoridation and dental health. Next slide. So a lot of what we do in the federal lane is that we have to oftentimes have authorizing language, which is then followed by appropriations language. And so we didn't just come up with this Healthy People initiative that is actually broader than oral health, but it was actually Title 17 of the Public Health Act. And what this charged the Office of Disease Prevention and Health Promotion to do was to formulate national goals, to establish strategies to achieve the goals, and to really highlight the areas of preventive health systems, and then to educate the appropriate use of health care. We also, with this initiative, focus on how to coordinate disease prevention and health promotion activities, and then the health education and information within HHS. So initially, with this particular act, was heavily focused on the activities within federal government, but it soon evolved to make sure that it was more inclusive of things outside of the federal government lane. The remaining areas or focus of this act was to coordinate such activities in the private sector. So to have that partnership engagement. And then there was a need to establish a national health information clearing system, which is essentially has become the healthypeople.gov website, where you can actually find out information about all of the topical areas and the objectives. And then this really was to support projects, conduct research, and disseminate information. Next slide. So this slide is important because it really speaks to when you're really looking at the differences among populations, what are you striving to do? I mean, the title of my slide focused on national oral health surveillance and specifically monitoring the oral health burden of disease. And so these goals have evolved over the iterations of Healthy People to focus more on the 2030, where it was more than just looking at reduction in disease burden, but it was also talking about elimination of disparities, achieving health equity, and really improving health literacy. Just really promoting an atmosphere where people were healthy across the lifespan as a goal. And then in 2030, there was further expansion of social, physical, and environmental environments in the context of social determinants of health. And then to also promote healthy development, healthy behaviors, and well being across the lifespan. And then finally, which was much different from the authorizing language, even though there was a private sector component, it it was a need to really see how people were actually using these objectives at a national level. And so engaging leadership, key constituents, and um, the public across sectors to take action and design policies that improve the health and well-being of everyone. And that's the critical thing. We collect a lot of data, but we want to make sure that we're inclusive of all the groups. And the only way you're going to know that is if you really take a definitive look at what your population consists of. And that's where we really rely on state and local entities to help us to really become more aware about what's going on at those levels. And then the federal government trying to make sure that we look at ways where we can expand the capacity in our sampling to really get a more inclusive study population. Next slide. So I'm going to talk more specifically now about the Healthy People objectives, and just keeping in mind that this wasn't just an arbitrary task. This was something that has authorizing language. And so it was really important to make sure that we engaged our constituents, in terms of these objectives. And right now we have 11 objectives and one developmental objective. One thing I will say that there has been in this most recent iteration, um, steps to kind of, you know, um, be conscious of the resources that it takes to actually put together something like this. So prior iterations of Healthy People, we had a lot more objectives. And I know a lot of people get concerned that, you know, why don't we have something that focuses on, diabetes and oral health and that type of thing? But it takes a lot of effort to really track this information. And then obviously the data is very expensive to collect as well. Next slide. And then we have 5 data sources, and the one that I'm going to focus on most is the National Health and Nutrition Examination Survey. But this is just to illustrate that there are other data sets that we use. And another one that I will also focus on is the Medical Expenditure Panel Survey. And really is just to let the audience here know a little bit about the distinctions between the different data sources. Next slide. So I'm going to now shift to focusing on some specific Healthy People objectives. And this is really where I'm going to link in and talk a little bit more about how it's challenging to get a broad or inclusive sample population. Next slide. So I'm going to focus on the older adults, and this one is focused on untreated dental decay. And really, the main takeaway with this is that you can definitely see the differences when you look at the proportion of adults age 35 to 44 with untreated dental decay. And this shows an overall estimate, which you can't tell very much about what's going on. There hasn't been a lot of change at all. But when you look at it by race ethnicity, you can definitely see that there are some clear distinctions in terms of the proportion that have untreated dental decay in terms of the prevalence numbers much higher than the baseline and then the current estimate. But one of the things that's really challenging, just like with getting adequate representation from rural and urban populations, we have the same challenges with respect to race ethnicity. And there is effort within federal government to be able to expand that. However, there are some challenges that I'm going to talk about a little bit more later. And then similarly, when you look at federal poverty level, you can definitely see that there are some strong differences for untreated dental decay when you look at it from an income standpoint. And then finally, with education as well. Next slide. And then two, this is really kind of showcasing the same thing, but looking at adults 65 and older and untreated dental decay on the occlusal surface or coronal surface of at least one permanent tooth. You see the similar pattern that we saw in the prior slide. When you just look at the data just from an overall perspective, it doesn't really tell you a whole lot in terms of the untreated dental decay, and there really hasn't been much improvement. But where you really start to see the differences, with respect to race, ethnicity, federal poverty level, and education, you really begin to see it tells a story, okay, what individuals are being impacted by. And I would like for us to get to a point where we not only just have these 3 main categories, but also be able to expand it for persons with disabilities, veteran status, and then obviously the rural versus urban and that type of thing. And even information about individuals' proximity to a dental provider. Next slide. So now I'm going to shift to periodontitis, really just to kind of show this pretty much the same thing, but looking at it from another highly prevalent condition. And so this again shows by race, ethnicity, and pretty much the same thing that you saw with adults and older adults in the context of untreated dental decay. You can definitely see some strong differences between non-Hispanic Black and Mexican American versus non-Hispanic White. Next slide. And then a similar pattern when you look at it by income, the federal poverty level. Next slide. And then again with education. So all of these factors, you may ask, why am I focusing on the race, ethnicity, and education and federal poverty level? I mean, all of these things can be used to kind of help shape in terms of program development and implementation. You want to know where the greatest need is. And so it's not just limited to race or to federal poverty level or education, but to really kind of tease out a number of things. It could even be utilization of going to a dentist in the past year, and we'll get into that shortly. Next slide. And then by behavior, smoking status is also another critical factor to really look at the populations that you serve. And here you can definitely see the disparity and the difference between current smokers and former smokers, as opposed to those who have never smoked. Next slide, please. And then also by diabetes status, persons with diabetes versus without. And this is another critical area in terms of really kind of understanding your population and making sure that you're inclusive of the groups that really have the greatest need. And we know there are studies that show that individuals with chronic conditions definitely have a higher prevalence of conditions like periodontitis, tooth loss, and untreated dental decay. Next slide. And then access to dental care. Next slide, please. So this particular objective, it comes from the Medical Expenditure Panel survey, and it's the leading health indicator for oral health. And with this, it's really the proportion of children and adolescents and adults who have used the oral health care system in the past year, focusing by race, ethnicity. And really the big thing here is when you look at by age group, you definitely can see some differences in the patterns, but then also you can see the difference in the utilization by race, ethnicity as well. Next slide. So now I'm finally going to get to the National Health and Nutrition Examination Survey. And what I'm going to do in this area is really kind of also outline why this is important, what we use it for, and that type of thing. But I'll start to get into some of the challenges of really being able to get that really broad and inclusive population that we really need to make sure that we're capturing everyone. And so not only just capturing people by age, but getting a robust sample so that we have enough information to really look at like persons with disabilities, veteran status, or by rural versus urban. So the National Health and Nutrition Examination Survey, one of the things that you need to take into account is, what makes this survey so unique? And of all of the NCHS surveys, none of the data collection systems for the US, they're not quite like the National Health and Nutrition Examination Survey. For most national surveys that collect data, they use interview format or a telephone or in person. And some may do some type of record abstraction. So I'm going to get into a little bit more detail about what makes NHANES so unique. Next slide. So basically for NHANES, is a population-based cross-sectional study survey administered by CDC's National Center for Health Statistics. It's a representative U.S. population sample of approximately 5,000 people per year. It monitors health and nutritional status of children and adults, like healthy people that we just talked about. And we talked about the authorizing language legislation to why we even have a healthy people framework. But the one critical thing about the National Health and Nutrition Examination Survey is the only national survey to include a physical examination, a dental examination, laboratory, and interview data. And I'm going to get into more details about some of the other areas that this survey covers over and beyond the oral health component. Next slide. So here is just really one of the challenges, as I had mentioned earlier, was how do we even get people to even participate in these surveys? And what NHANES has done is really try to make the effort to really engage the communities that they work with. So they do a lot of work prior to even coming into the community to learn more about where the greatest needs are, because they have to recruit people from those areas. So they do a lot of things door to door, face-to-face interviews, but there's a lot of things that go on even prior to getting to that particular point. Because the thing about it is to get that robust sample so that you can have people representing, rural and urban areas, you really need to be able to recruit them. Next slide. So for the household interview portion, we get demographic information. We get a broad range of health conditions and healthcare utilization. So it's not just limited to dental, but medical as well. We get information on prescription medication and dietary supplement use, and then also health insurance. Next slide. And as I mentioned, the sampling part is really critical. And one of the things that we are required, there is a Public Health Service Act 42 USC that talks about how we have to maintain information and keep all of that information confidential. And that's one of the greatest concerns when you're trying to recruit someone to a survey, is that they want to know, how is this information going to be used? Can it be identified? Can it be shared with anyone? And there's really strict rules with respect to how we manage that data and how we store that data. And it really lends itself into whether or not a person is going to really participate in a survey, because the reality now is that we live in an environment where people, they scrutinize more, they have concerns about how their information is going to be used. They could have a distrust or an apprehension about being a part of a large survey as a survey participant. Next slide. So why do we even use NHANES data? What does it actually accomplish? Next slide. When I think about it, one of the most important things that we do at CDC from a public health standpoint is we really want to get nationally representative data, so that we can get as accurate and an actual measurement of the data. We want to be able to integrate interview and examination findings. We want to maintain a high quality of data collection in the way we process the data and analyze the data. And then we want to be responsive and relevant to the current and future data needs. And so there is an extensive process to really not only be able to recruit the number of people that we need that is representative of the communities that we go in, but we also want to be able to make sure, are the questions that we have on the questionnaire, are they adequate to really get at to what might be hindering some individuals to get access to care or be familiar with healthy eating habits and that type of thing. So it's a broad array of information. So we're not just looking at the way the person's health actually presents at a point in time, but we're also trying to look at maybe behaviors that may have influenced that. Or do they have insurance or not? Do they get to go visit a dentist? Do they go, to a medical doctor? Have they been told that they have diabetes? But then we can also back that up with the laboratory component, because everyone does a A1C that comes through the survey. Next slide. And then also we want to look at nutritional monitoring, surveillance reference data. That's a big thing that CDC does. And then to monitor chemical or pollutant exposure, disease control, and as I already had mentioned, track health behaviors and any risk for certain poor health outcomes. Next slide. And then also there's another area of oral epidemiology. How do we translate what we see into information that can be used to monitor oral disease and conditions? So using epidemiologic indices and coding criteria, using standardized measurement procedures to facilitate comparisons across populations. Next slide. And then also NHANES oral health data is used specifically to estimate the prevalence of key oral diseases and conditions in the US and explore associations between oral health and other health measures or conditions, like I mentioned earlier in terms of diabetes, but not just limited to that, to smoking status, et cetera. Next slide. And we don't just keep this information and just not do anything with it. I mean, the dissemination from a broad perspective, not just for the research community, but for the communities, at the local level too. This is one of the reports that was done in the past. And really, I'm just showing this to just kind of illustrate that the government does its best to get out different reports that kind of show trends in oral health status at times. And so next slide. Um, it also has been used for reports like the 2000 Oral Health in America, a report of the Surgeon General. Next slide. And then also the most recent report that was released in 2021, led out by NIH, but really was a collaborative effort across all federal agencies and individuals in academia and research. And it was really a follow-up to that first 2000 report. Next slide. And then one of the things I wanted to kind of talk about, we know the impact that COVID had on the community. And so this is all the more reason to want to make sure that we're being as inclusive as possible with respect to the data that we collected. And for the oral health component, we actually had to pause efforts in March 2020, and then we were able to use part of that data for the 2019-2020. There is information that's through restricted access, which only means that you just have to write a proposal to access that information. But what we did to make this data more usable is to have it combined with the 17-18 data cycle. But during the time of 2021-2023, we weren't able to do any examinations or anything like that. However, we did do information on self-report measures related to quality of life. And the first wave of that data was released in September of this year. Next slide. And so beginning in 2025 and 2026, we're really trying to look at ways where we can really make the data more robust. I mean, when you think about it, we had to kind of pause everything at 2020. So it's really urgent that we kind of reassess what's going on. We're going to still do the 5,000 study participants. We're going to return to oversampling groups. And one of the things that I wanted to mention is that when you think about some of these populations that are not always represented to the extent possible, NHANES does collect pretty robust information. A lot of times what they have to do is to really make it so that they try to get as many people as possible. So sometimes they have to end up oversampling the Hispanic community because for whatever reason, sometimes the recruitment, it can be a huge challenge. Also with non-Hispanic Black people, and then for children as well. Um, in general, we try to collect information across the lifespan, and definitely that would include older adults. And we really tend to focus on this 2-year data because it makes it stronger in the sample. And so there is information that's collected on individuals like rural people living in rural areas and urban areas. But if we don't get enough people to actually participate in those groups, we have to end up putting that data in what they call the restricted data access. You can still use it, but what has to happen is that you would have to use multiple years of data to get adequate samples so that you can really look at in those individuals that live in rural areas, what does that demographic look like when you think about it by race, ethnicity, education, and federal poverty level. So these years together, even just a single year is considered to be nationally representative. Next slide. So we have a number of partners. We really try to engage with as many people as possible, that is NCHS. And so this here is just really to kind of illustrate the other individuals that are kind of advocating. You've got birth defects on here. You've got, the National Institute for Diabetes and Digestive and Kidney Diseases, the Food and Nutrition Service, et cetera. So it's a lot of different partnerships with NHANES to try to get as much data as we possibly can from all different populations. So definitely that partnership with NCHS is really critical to try to work to get as much information as possible. Um, And then what we've been trying to do in terms of methodological improvements is are doing something a little bit different come 2025, 2026, and that includes getting 5 teams out into the field. They want to increase the number of primary sampling units from 15 to 20, because if we can increase that sample size, the more likely we are to get, some of those groups like persons with disabilities or veteran status, and then also definitely the rural versus urban. And just increasing those numbers, really helps to increase statistical power. We get more stable estimates. We don't have to end up putting data in the restricted data source. And so we're really doing a lot more. The plan is to do more with census information derived from public health, public use microdata areas. And it just really helps to improve that sampling power, the statistical power. Next slide. And so this is just an illustration, a picture of what the new unit. The one on the bottom was the traditional mobile examination centers, or MECs as they're called. And there were like 3 of them put together. And now they're a little bit more mobile for sure, in the sense that they want to be able to get across to different communities more quickly. It will allow them to be able to set up better, but they still want to make sure that they do that scanning of the community that they're going to in advance, and try to get the buy-in from the community so that they can get good response rates, because that's really critical. The more people that we can get to participate, the more robust the sample and the more diverse or inclusive the sample would be. Next slide. And so this is some of the exam content over and beyond the oral health content. Their continuing content is urine collection, blood pressure, phlebotomy, the interview, and then returning to NHANES. Obviously, oral health is here, and that is from 1 year and older. They have vision, audiometry, then the osteoporosis, DEXA, and then HPV. You can see here on the side many more as well. Next slide. And then with the laboratory content, this is just a high level overview of the different profiles they do: diabetes, lipid, liver, kidney, etc. Infectious disease profile, allergy testing, environmental profile, blood metals, everything you can possibly think of. And then also the water and fluoride levels. Next slide. So another thing that the NCHS is doing is looking at processes for efficiency. A lot of this has to do with the sample, but then also reducing the participant burden. Because another thing that's challenging is some people don't really want to devote that amount of time to actually go through this process. So we have to really figure out ways to incentivize those individuals that are we're wanting to participate. So we're really looking at all of those aspects as well. And then the technology that we use to actually store the information and be able to pull the data together more readily so that it can be made public in terms of for analytical purposes. Next slide. So for the 2025-26 oral health components, we really want to, really capture what's going on post-COVID. Adults with fair or poor oral health, we know, have more dental disease and less access to dental care. Primary care providers can help their patients maintain their oral health. We want to educate patients with fair and poor health about their higher risk for dental disease, stressing the importance of preventive care, screening patients for oral conditions, and then referring patients to a dentist. So part of the effort to really scan the community is they want to make sure that they don't just go through this process and then there's not any resources for them. There's a lot of effort to really get a list of providers that maybe have maybe a reduced or sliding scale in terms of the to help individuals to get the care, not just even for dental, but for medical care as well. So they're given a full report on what everything looks like. And I think I have a few slides with respect to that. Next slide. This one is actually just focusing on that CDC is the lead collaborator on the oral health component. And I already mentioned to you that we have a questionnaire, we have the laboratory, and then we have the oral health assessment, which is essentially the examination or the screening. And then we have the target group is 1 years and older. We have 22 questions on the home interview. And those topics have like last visit to the dentist, direct conversations with the dentist or oral health provider about health or habits, oral cancer screening, overall health or periodontal disease self-report, and then the tap water consumption in the home. Next slide. And as I mentioned before, this one focuses more on why we even collect surveillance data. So this is the Public Health Service Act that the HHS Secretary has supported, that would include that we do an oral health assessment and that this information should be updated at least every 6 years. And as I mentioned earlier, it serves as the foundation for supporting the efforts for the Healthy People 2030 oral health objectives. Next slide. And this is the critical part here. I mean, in addition, the challenges we often have is, just being able to recruit people. We may get a lot of people from a number of different racial, ethnic backgrounds. We could get information about persons with disabilities. However, sometimes, like I said, the sample is really, it can be challenging. But one of the things that we try to do, or that is NCHS tries to do, is to do a report of the findings. This is specific for the oral health assessment, but they also give all of the outcomes for the laboratory work, whether it's A1C or other things. So it'll give them all of the assessment results. It will look at, conditions that have been identified for referral. Next slide. Also, they give a level of recommendation of care of how quickly they need to see a dentist. But it's not just telling them they need to go. They look at the community that they're in and look at ways to, give them some viable options. Next slide. And then we have QA and which is just quality assurance and quality control, just making sure that as we do these exams, we're really trying to make sure that we have everything in order from a qualitative perspective and a quantitative perspective. Next slide. And then this is another critical thing that I mentioned earlier about participation, participant burden and compensation. When you are involved in an exam like this, it can take up to 3.5 hours. And some people do opt out of certain things, but we try to really incentivize them to participate in all of it. And then for children, it's 1 to 2 hours. There's a fee that, kind of a stipend that we give them, and then also transportation. And then any other information that we can give them post-exam to get them to where they need, especially if there's been areas of concern that have been identified. Next slide. And so finally, I want to make sure that we have enough time to engage in some questions. Some of the key takeaways is that when you're trying to get representative data, and this, I mean, it can be inclusive for everyone. And I didn't mention it, but even for mental health, we definitely want to, make sure that we don't exclude anyone. And we want to make sure that we're asking the right questions or doing the right exams to really capture what is beneficial for the content that we include. And one of the things that CDC has done as an agency is that they've formed a work group, and there is a division of oral health representation on this group. And they have worked with the larger work group to come up with a CDC rural health strategic plan and a CDC rural public health action plan. In addition, there have been a lot of efforts to really strategize in terms of our messaging and how we recruit study participants, and then establishing key partners in the community. So more emphasis is being placed on the communities that we're actually going into to collect the sample. How can we engage critical partners because we know that they know greater about the need and those individuals that could benefit, but then also educating people and creating awareness of why this is important and to just give them reassurances that it's really to help on a broader level to make sure that we're doing all that we can so that everybody can have good health and definitely good oral health. I think that's my last slide. Thank you so much for your attention. And I'm really looking forward to the Q&A period.
Thank you so much, Gina. I hope everyone will join me in giving a virtual round of applause to that presentation. We, again, so appreciate your time. I think what was really salient is pulling in those best practices and the challenges that you face, right? Even at our highest level of data collection, there's those challenges. And our hope with highlighting that piece and having Dr. Thornton Evans with us here today is that we can take those lessons learned and bring them back into our community. So we have some discussion questions to guide us in that, but I want to pause and see what questions we can ask and answer Dr. Thornton Evans before we go into that piece. And I just invite folks to come on camera. You can come off mute. We have multiple screens here. So yes, Helene.
Hi, Gina. Thank you. That was really delightful, as I would expect. With the aging population and many of us older adults and the remainder of, HIV infection, which I know we addressed together about 10 years ago, how are we looking at that kind of trajectory and the trends in oral disease connected too with some of the labs that you're talking about, like an A1C or blood pressure? What are you thinking we can do with that?
I mean, I think there's a number of things. I think one of the things that the trend data has actually shown when we look at 1999 to 2004 and and then from 2013 to 2016, I'll just focus on those time periods because then I get into the pandemic arena, is that we've seen great improvements in terms of for children, especially. And we know that policy definitely influences that. But one of the things that's notable to me, to get to your point in terms of, adults, working age adults and older adults, is that we haven't seen much improvement at all. But we also know that there's challenges in that policy lane for that. And I think one of the things that's critical is to really show that oral health is important across the lifespan. We know it, but I don't think we want to make sure our medical counterparts and people in the insurance lane, the payer part, they really are fully aware that, there's a lot of need there and that there can be a cost effective um, benefit from actually being able to include a component related to oral health, whether it's related to Medicare or whether it's just a standard of care, and making sure that those persons with multiple chronic conditions know the importance of their oral health. I know some insurance companies have really seen a huge benefit in adding dental, like especially for persons that have diabetes. They've seen improvements in A1C levels, and that's supported by a recent Cochrane review. And I think one of the things that CDC, along with NIDCR and CMS, we were able to be sponsors for the NASEM workshop for oral health across the lifespan, which is on this Monday and Tuesday coming up. So I think those are really key opportunities to really show that oral health is important no matter what your age is. And if you're in a nursing home or, a memory center, or you're being hospitalized for various conditions, that oral health is still important and it has a strong influence on the outcomes of individuals that have multiple chronic conditions and such. So that's one way, just increasing the awareness, trying to really do the research that shows that that there is a need and that there are innovative ways that we can address some of those challenges.
Thank you. And Helene, I see you have a follow-up piece there in the chat about cross-referencing oral health and systemic with the medical component. Um, I think that there's perhaps some proxies you were talking about, Dr. Thornton Evans, within the data collection to make those connections. I don't know if you wanted to say anything else about that, Helene.
No, I think, the point Gina's making is that we know what we know. How do we get everyone else to know it? If they know what we do can have an impact on the health outcomes of their patients, perhaps they'll be more conducive or in favor of promoting the concept of go to a dentist, get a dental exam, get dental care. So I'm just wondering in the, NHANES, where we can connect the dots to be
Mhm.
able to say, if you're looking at this and we're looking at this, are we not in a sense looking at the same outcomes?
Yeah, and I think that's where we need to really go beyond just the dental community or even those individuals that have worked in the dental community. We really need to work more exclusively or intentionally, I should say, with like the American Diabetes Association. And like for us at CDC in the Division of Oral Health, we have not 8 other divisions that we could partner with, which include Division of Diabetes Translation, the Division of Nutrition, Physical Activity, and Obesity, the Office on Smoking of Health, just to name a few. But we need to be intentional about those partnerships and, you know, connect the dots, so to speak, that way. Because we know what the data shows. We know the connection between oral health and systemic conditions. I think really is getting our other counterparts to really engage in the dialogue and see that there is a value. But, really what I focus on a lot is really, the data. We have the data. We just need to really make sure that we're having the right conversations with the right people and that when we do come together, like for this NASM, that we have all of the right people there in the room or virtually to hear the dialogue and to provide some input so that we can really truly integrate oral health into overall health.
That's fantastic. Thank you. I think we have time for one more comment question. I invite questions if folks have them. And if not, I'm curious, based on what Dr. Thornton Evans was just saying and making those connections, again, we're kind of talking about the highest level of data collection. Are folks doing anything at the local level, making those partnerships and those connections at the local or state level in their programming that has been successful? So I invite folks to comment on that or share a question outside of that in our last few minutes before we close out.
I would just like to say, I really appreciate all of you tuning in to this. And, this was really kind of a high level overview of the efforts, but, it really represents some of the challenges or really, I like to look at it a little bit more positively, opportunities to really build more robust data because it's definitely critical. But I think one of the things that we really have to be mindful of is that we do have to increase awareness about the importance of oral health, but we also need to really be able, especially for NCHS, as they go out into the field, to be able to make the case because people do have legitimate concerns and we can't minimize that. We have to be able to address their concerns in terms of being able to trust the process, to be able to feel comfortable that their information is not going to be shared in a reckless way. So there are a lot of standards, and I just wanted to share with you all it's very costly to collect this information too and to oversample. So that's another really critical part. It's like you want to be inclusive as many people as possible, but it does take efforts from the broader perspective, not just within federal government, but from you all and the areas that you work in to make the case that, hey, we need this information, you know, and so that it will enable us to get additional funding to oversample those critical populations. And I know in CHS, they're always looking for opportunities to partner with various organizations so that they can do that. And sometimes they may do it just for a couple of data cycles, but at least it gives important data that can really make the case that we need to look deeper into this and we need to do this more frequently. And this is how we can get, more people to participate in the survey.
Yeah, and Catherine's asking, how can we help in the NHANES efforts? So, in our last few minutes, Gina, do you have any pieces to share of what folks can go out to educate or to join or to participate? What can folks do to support?
Well, we definitely have quite a bit of information on the website about NHANES and then also on the NHANES website itself. But I mean, I think, if there's specific things that you might be interested in, please reach out to me. I would love to hear from you. I think what I've been really trying to do is promote more about, when we release data and try to do it as quickly as possible. And not only just from NHANES, but state-specific data from behavioral risk factor surveillance system. So I'm just trying to look for ways to actually get the information out and to do translational research because it's really critical. No one wants to always just read a peer-reviewed journal article. We need to really think about ways that we can get data out that's meaningful, but gives a high-level snapshot of the data that people can use. And so I'm really looking at, how can we just go beyond maybe just some of the multi-page, really complex analysis because we just really want people to be informed and we want them to be able to take those sound bites that can be really critical for the work that they're doing or for when they're applying for various funding sources as well.
Fantastic. Thank you. We just have a few more minutes. So, Sam, I'm hoping you can pull up our slides so I can share our next steps. And I see folks continuing to participate in the chat. That says to me where we are feeling energized and we're feeling motivated by this information. Gina, what you said about the translational research, that's what we strive to do here at AIDPH and take our work and put it into pieces that folks can use when they're developing programming, talking to decision makers, applying for grants. So I invite folks to continue the conversation with your colleagues, with your peers, and in programming like this, and look for our future programming, which is part of our next steps. So as I mentioned at the top of our call, CEUs are available for today's session. I want to take a quick second and talk about this a little more in detail. Again, there's many folks here who have participated in our Rural Oral Health Echo series for several years now. And I just want to note that we are changing our CEU process a little bit. This link that was just shared in the chat by Rahel will bring you to our Academy, which is our digital learning platform where all of our programming lives. It will say register now. You can register for free and get your CEU by completing the evaluation form just like you normally would. Oh, was someone saying something? Okay. So just want to share if you've gotten CEUs with us in the past, this will look a little bit different. It is still free. It is free to register and your CEU will be housed in the Academy in easily accessible place. If you have any questions about that, please let us know. We will share additional details again on that via email just so everything is clear. We also said at the top of the call, our resources, our recordings, and the competency evaluation for today's session will be available on our website and our academy. So folks can go through, share with colleagues, review if they weren't able to attend for the whole time, and take that competency quiz to work towards their certificate for this year's series. We have one session left for the year. I can't believe we're in November. Our final session will be in December, focusing on rural oral health equity and disabilities communities. And finally, I also noted that registration is open for our colloquium, which is our annual in-person conference. It's being held in Chicago this year ahead of midwinter, and it will be February 19th and 20th. We are posting the registration link for the colloquium in the chat, and we are posting the registration link for our December fifth session in the chat as well. If you have any follow-up questions, you can reach us via email, and keep an eye out for CEU information and materials being posted. Thank you again. Big thank you to Dr. Gina Thornton Evans for her time with us today, and thank you all for your engagement and your participation in this important work. Take care, everyone.